Welcome to the Adelphi, New York Statewide Breast Cancer Hotline and Support Program STEP video series. I'm Dr. Tanna, and I'll be discussing innovations in reconstruction and body image. Approximately 1 in 8 women develop breast cancer. In addition, about 1 in every 500 women in the United States has a gene mutation such as the BRCA1 or BRCA2 gene that makes them susceptible to breast cancer. What we see is that an increasing number of women are opting for a mastectomy, whereby the breast is surgically removed. And every year in the United States, over 100,000 women are having a mastectomy. In fact, the rate of double mastectomy has increased 5-fold in the past 10 years. Breast reconstruction is important as it serves to rebuild and restore the look and feel of the breast after a mastectomy. When we look at the native breast, we have the skin envelope and the nipple in the front. Moving behind that, we have the breast tissue, and then we have the muscle. In a mastectomy, the underlying breast tissue depicted here is removed, and what's left after a mastectomy is that empty skin envelope. And breast reconstruction is essentially refilling that void. It's reestablishing that white space after the mastectomy. When we look at options for breast reconstruction, we really can consider them in 3 categories. The first category is replacing what has been lost with an implant. And at the top of the image, you can see a blue-colored breast implant that's placed. Alternatively, a woman can choose to use her own tissue, what we call a flap. A flap is using an area of excess fat from the body to rebuild the breast. Depicted at the bottom is an image of a flap reconstruction. And then all the way to the right is the third cohort, what we call hybrid breast reconstruction. Hybrid breast reconstruction is when a woman can use the fat that she has and supplement it with either an implant or acellular dermal matrix to enhance the volume and provide the desired breast reconstruction volume. Let's look at the first category, implant reconstruction. When we place an implant, it can be placed below the pectoralis muscle, which is the chest muscle, or it can be placed in front of the muscle. To the left, you'll see what's called subpectoral reconstruction, and that's where the implant is placed underneath the muscle. And to the right, you can see what's called prepectoral reconstruction, which is placing the implant in front of the muscle. The advantage of placing it under the muscle is that you are adding more soft tissue in front of the implant. The disadvantage, though, is that by elevating the pectoralis muscle, the chest muscle, and placing the implant underneath it, you can create something called an animation deformity, whereby the implant moves as the pectoralis muscle is functioning. In addition, it can create a sensation of pressure or pain as the implant is in what we call a non-anatomical plane. Alternatively, by placing the implant in front of the chest muscle, you're avoiding that pressure, pain, and animation deformity, but the implant is more visible and palpable. By placing the implant in front, you often necessitate the use of acellular dermal matrix or a mesh to provide soft tissue camouflage. Let's move on to the second category of reconstruction, flap reconstruction, which means utilizing a woman's own tissue, sometimes also referred to as natural tissue reconstruction. The hallmark of natural tissue reconstruction is using a woman's own fat based on a blood supply, namely an artery and a vein. As depicted here, you see the red is the artery that feeds the flap and blue the vein that drains the flap. We can take tissue from various places on the body. These places all have a blood vessel that feeds it, and the names of those flaps are based on those arteries and veins that feed that. Most commonly, we take tissue from the lower abdomen. That is called the DIEP flap. Women who don't have fat in that distribution or have had previous abdominal surgery not allowing for that, we can sometimes look at alternative sites. Those sites include the thigh or the flank. The thigh flaps include the pap flap or the tug flap, and the flank includes the lap flap. In a flap reconstruction, it's important to remember that the tissue is removed from one area of the body, completely separated from that area, but transferred with blood supply to where the breast is. Therefore, you have two surgical sites. You have the breast where the reconstruction is occurring and the donor site where the tissue is coming from. Let's look at an example with the deep inferior epigastric artery perforator flap. And in this flap, we're looking at the tissue in the lower abdomen. We're looking more specifically at the tissue below the belly button. And we take the tissue in an elliptical fashion. It's important to remember that we have to be able to close the area where the tissue is taken from. So while we're making an elliptical shape to take it, we are creating a linear or a single scar in an aesthetically pleasing area. The DIEP flap is the most common flap procedure because the tissue is there, and it allows for the mastectomy and the reconstruction to often be performed at the same time. Alternative sites when the lower abdomen is not available include the thigh and the flank. This is an example, the profunda artery perforator flap, where we take tissue from the back of the thigh instead of the lower abdomen. This is useful in patients who lack fat at the lower abdomen or patients who are not candidates because of previous abdominal surgery for the DIEP flap. The reason it's not the first choice is because it often requires position changes and it's not as straightforward as the lower abdomen to take from. But it does remain a good source of tissue for women who are interested in using their own tissue, and the abdomen is not a source. Alternatively, we can look at the flank, what some people refer to as the love handle region. And again, when the abdomen is not a good source, we can look at this source. The flank often requires positional changes, and that's why it's not the go-to as an initial source of reconstruction. This is an example of the flank and taking tissue from the love handle region as a lap flap for breast reconstruction. Let's look at the third category of breast reconstruction. A hybrid breast reconstruction is really combining the first two categories. It's utilizing a flap, a woman's own tissue to rebuild the breast, and making up the deficiency in volume, meaning what a woman has to rebuild the breast and what she desires or what is required, making that up with an implant or the acellular dermal matrix that's required to hold the implant in place. Depicted here, you can see the flap in the front and the blue implant behind. The flap does have the artery that feeds it and the vein that drains it, and the implant is present in front of the muscle. This is a good option for women who lack the adequate volume to meet what their desired breast reconstruction volume is. It really combines both a flap and an implant, and it has the advantages and disadvantages of both. Here's an example of a hybrid breast reconstruction with a flap from the abdomen, the DIEP flap, and a small implant placed in front of the muscle. Alternatively, a hybrid breast reconstruction can be performed with a flap and acellular dermal matrix in lieu of an implant. By avoiding the implant, we are relying solely on the volume provided by the acellular dermal matrix. And you can see images here of the acellular dermal matrix that has been put into various shapes and configurations to add volume. This is an example of a hybrid breast reconstruction with a flap and the acellular dermal matrix. Let's discuss breast neurotization. In a mastectomy, the nerves that are feeding the breast are cut with the removal of the breast. And that often leaves women with an insensate breast, a breast that lacks sensation. In an attempt to improve the sensation after a mastectomy, there are several nerve reconstruction techniques that are available. We call this breast neurotization. In breast neurotization, we're performing a nerve reconstruction. The cut nerve ends from the mastectomy are identified. And you can see circled in blue those nerve endings that are cut. In an attempt to improve sensation, what we can do is find those nerve endings and suture them to nerve endings in the flap. When we're taking tissue from somewhere in the body, let's say, for example, the abdomen, not only are we taking an artery or vein, but we can actually identify a nerve. By taking the nerve that was cut from the mastectomy and suturing it to a nerve in the flap, we can make an attempt to reconstruct those nerves and improve sensation. That is called breast neurotization, and it has been a recent advancement in breast reconstruction. Here is a picture of a DIEP flap, and you can see in your top left, you can see the artery and vein connection, and then you can also see the nerve connection that attempts at improving sensation to the breast after mastectomy. Moving on to another innovation and advancement in breast reconstruction is the field of robotic breast surgery. When we talk about robotic breast surgery, we're talking about 3 distinct procedures where robotic assistance has shown promise in breast reconstruction. The first is in performing the mastectomy, what we call a robotic mastectomy. The second and the third are in the breast reconstruction arena, and that is using the robotic assistance for the DIEP flap reconstruction and in microsurgery. It's important to understand that at the console is the surgeon. The robot is not performing the surgery independently, and the robot is a tool like other instruments in surgery. When we look at traditional forms of mastectomy, they all require an incision of some form on the breast itself. These options include an inframammary fold incision, which means an incision in the fold of the breast, or a periareolar incision, where there's an incision placed somewhere in relation to the nipple areola complex. That can be extending laterally or outward, or inferiorly or downward in a vertical fashion. It's important to understand that these incisions, whether it's an inframammary fold incision or a periareolar incision, is placing an incision on the actual breast. And that causes additional ischemia to the skin and the nipple, ischemia being suffocation. Robotic breast surgery aims to reduce the cutting of blood supply by placing the incision off the breast. As the incision is placed far away from the breast and it's small, the need for robotic assistance becomes more important. In a robotic mastectomy, the incision is placed along the lateral bra line, parallel to the nipple. You can see a patient here in surgery, an animation where a woman is lying on her back, the arm is up, and the red line depicts where the incision is. By placing the incision off the breast, we're doing less cutting on the actual breast, preserving additional blood supply. Robotic assistance has shown promise in also breast reconstruction. One area has been the robotic DIEP flap, also known as the Robo-DIEP flap. In DIEP flap breast reconstruction, where the tissue is being taken from the lower abdomen, there is a need to follow those blood vessels from where they come off. And it requires us going through the rectus muscle, the six-pack muscle of the abdomen. We're not taking that muscle, but we are going through it. We're passing through it. In a traditional DIEP flap, pictured on your left, we're often having to open that muscle for 12 or 13 centimeters to gain access to those blood vessels. When you open the six-pack muscle, you are causing potentially some weakness and additional surgical sites. In a robotic DIEP flap breast reconstruction, you're able to limit that opening to 3 or 4 centimeters as compared to the 12 or 13 centimeters, and you're able to do the remainder of the work intra-abdominal with the assistance of the robot. Here's an example of a patient whose blood vessel you can see coursing from the fat into the rectus six-pack muscle, and that remainder will be done with the assistance of robotics. Last, in terms of robotic assistance in reconstruction, is microsurgery. When transferring tissue on arteries and veins, these vessels are about 1 millimeter to 2 millimeters. This is very small and highly technical. By using robotics, as you can see on the right, we're able to eliminate human error, things like tremor, to give precision and improve outcomes in breast reconstruction. Finally, looking at post-mastectomy breast reconstruction and body image, there have been many innovations and advancements that have yielded improvement in this space. Body image is very important. We know that breast cancer patients often face personal and physical challenges, especially those that undergo chemotherapy, radiation, mastectomy, or lumpectomy. And it's important to understand the individuality of this surgical process. Each woman's journey is unique. Some feel empowered while others struggle with acceptance. And breast reconstruction is highly personalized. It can help women regain their sense of femininity, restore confidence, reclaim sexuality, and feel whole again. Over the last couple of decades, advancements in breast reconstruction have enabled patients to look and feel their best, to really look their own normal. So as scars fade, emotions can also be processed. When we meet with patients, we consider all the factors that influence body image. We look at the timing of reconstruction. Can it be done at the same time as a mastectomy or a lumpectomy, what we call immediate reconstruction? Or does it need to be done in a separate, staged, delayed fashion? We also look at the type of reconstruction. What may be good for one woman may not be good for the other. There's a whole array of options looking at natural tissue reconstruction, implant reconstruction, nipple-sparing procedures. These are all taken into the context of a patient preference and body habitus. We recognize individual experiences and we adjust for those body changes. It's important to understand that there is a team of providers ranging from counselors who look at psychosocial health and support groups such as Adelphi that can help patients cope with changes to body image and recovery. It's important to understand that body image is individualized and reconstruction is a personal choice. There is no right or wrong decision. It's really up to a woman. It's her choice. When you look at women who choose not to do reconstruction, some women feel confident and embrace their new body. Alternatively, there may be women who forego reconstruction and experience distress with that decision, difficulty with clothing, or discomfort in intimate settings. When you look at women who have had reconstruction, for some, it can be a restoration of form, restoring wholeness. Alternatively, there may be others who have had reconstruction who may struggle with scars, changes in sensation, or differences from their natural breasts. Here are examples of patients who've had nipple-sparing mastectomy. Nipple-sparing mastectomy has been shown to offer better cosmesis and patient satisfaction. There are studies also showing there is an improved sense of self-image by the patient with nipple-sparing reconstruction. Alternatively, when a woman is not able to preserve the nipple and she pursues a nipple reconstruction, there have also been studies that show with nipple reconstruction as compared to foregoing nipple reconstruction, there's better cosmesis, satisfaction, and improved self-image. Finally, it's important to understand that all of these procedures are part of a journey. This journey spans over time and stages, and women may require additional procedures to achieve their desired self-image. Fat grafting is a technique where fat is harvested or taken from an area of excess. Unlike a flap where it's transferred with blood supply, this fat is placed with no blood supply. This does limit the amount of fat that can be placed, and therefore it's often used to improve contour and soft tissue coverage. In addition, because we are limited in how much volume can be achieved with fat grafting, it oftentimes requires more than one surgical stage. It's important to understand that breast reconstruction is part of a larger journey. There are coping mechanisms and adjustment that occur after a mastectomy reconstruction. It's important that patients acknowledge emotions. These can be a whirlwind of emotions: grief, relief, gratitude, frustration. We encourage patients to seek out therapy and support groups to help process these feelings. And it's important to focus on what your body can do, not just how it looks. We acknowledge that there are compensatory behaviors to help rebuild confidence. For example, choosing clothing that makes you feel comfortable and confident. Engaging in physical activities that reconnect you with your body and improve confidence. Seeking professional help, not just medical, but psychological if desired. Finally, empowerment and self-acceptance are paramount to the journey's success. Your body tells a story of strength and resilience. Beauty is not defined by breasts. It's in the confidence, self-love, and the life you continue to live. Thank you for joining us. We hope you enjoyed the STEP program video series. For more information, visit us online.